Welcome to the Highlights Show. I'm Phil Kessler.
And I'm Amy Ryan. It's great to be here. Wow. That was a lot to take in, wasn't it? Just finishing up that session on pediatric growth hormone.
Yeah, really dense. So much clinical detail.
It felt like I got, a ton of new data points, but the thing that hit me hardest right away was this tension.
Between the science and the reality.
Exactly. Between what we can technically do medically and what's actually practical or feasible on the ground. It felt stark.
Yeah, and the presenter didn't shy away from that at all. It seemed like every time they discussed an indication, GHD, Turner, Prader-Willi, SGA, it was immediately followed by, okay, but how do you implement this? Especially thinking about resource limits.
Right. Okay, let's get into that then, because that feasibility part it's everything, isn't it? If you had to pick one thing from the session, what felt like the most profound challenge for clinicians, the toughest decision point?
For me, I think it really crystallized around idiopathic short stature, ISS, because it is an approved indication, but the whole cost-benefit thing is just so tricky.
Oh, absolutely. The ISS data really jumped out. You've got a kid who's clearly short, significantly so, but doesn't tick the boxes for classic GH deficiency. Still, treatment's an option. What did you make of the outcome data they presented versus, everything involved?
Well, they were very direct about it.
Yeah.
The results are consistently described as modest. And apparently using GH for ISS is still pretty controversial globally.
Modest. What did that translate to?
The number they kept citing was an average final height gain of about 6 centimeters.
6 centimeters.
Over roughly 6 years of treatment.
6 years. Okay. That number, 6 centimeters, it sounds small on its own, but when you frame it like that, 6 years of daily shots.
Exactly. That's the commitment you're asking families and health systems to make. Daily subcutaneous injections for 6 years, potentially, for a gain that, it might not even change their clothing size much, right?
Yeah.
Let alone significantly shift their position on the growth chart.
Yeah.
And the presenter really emphasized weighing that modest physical outcome against these huge practical things and psychosocial things too.
Like the medicalization aspect.
You're basically telling a child they need daily medical treatment to fix something that isn't technically a disease. What does that do to their self-perception? It's a heavy consideration alongside the time, the effort, and of course the massive cost. It really forces you to think about what benefit even means there.
Okay, so if ISS treatment is that complicated, the diagnostics aren't exactly simple either. It felt like a big theme was moving away from needing one single gold standard test for GHD.
Definitely. Which makes sense in endocrinology. Things are rarely black and white.
So what were the main limitations they highlighted with the traditional testing approach?
Well, the biggest one starts with GH itself, right? It's pulsatile. Comes out in bursts.
Meaning a random blood draw is useless.
Totally useless for diagnosis.
Right.
It's just a snapshot. So you have to use other methods, surrogates, or stim testing.
Which brings us to IGF-1 and IGF-BP3. Useful screens, they said, but sensitive.
Very sensitive to age, sex, puberty stage, and hugely sensitive to nutrition.
Yeah, they made a point about that.
Mm-hmm. And that's why they highlighted that IGF-BP3 is often preferred, especially in really young kids, or there's malnutrition concerns. Apparently, it's less affected by poor nutrition than IGF-1 is. Knowing that difference seems pretty key for accurate screening.
But the really challenging idea, the one that kind of pushes against standard practice, was potentially skipping the GH stimulation test altogether?
Yeah, that was a big moment.
Yeah.
Because for many, that's the test, the confirmation.
So how could you justify skipping it?
It's about moving to a more integrated clinical picture. The argument was, look, if you have really severe growth failure, documented, sustained, falling way off the curve, and you have other pituitary issues, and the MRI shows clear pituitary abnormality.
Like structural problems.
Right. If you have that kind of triad of evidence, doing a stim test probably isn't going to change your management decision. The diagnosis is pretty clear from the overall picture.
So you're essentially trading a test known for variability and being cumbersome.
And expensive.
It's expensive, yeah. For the certainty you get from the clinical signs and the imaging. It makes sense, especially when they also mentioned that the cutoffs for stim tests keep changing anyway, depending on the assay. Lots of places using 5 to 7 nanograms per ml now. Not the older, higher levels. It's all about putting imperfect pieces together.
It really is. And that kind of pragmatism, that focus on integrating data, leads straight into the massive issue, resources.
The cost, yeah. If diagnostics are tricky, the economics, particularly outside high-income settings, seem almost impossible.
We have to talk about that figure they gave. I mean, I actually wrote it down. It just puts everything into such different light ethically when you think about health budgets globally.
What was the number again?
Around 30,000 US dollars per patient per year.
$30,000 per year. Wow. Okay, in so many places, that's unimaginable for one child's treatment for stature. That could be an entire clinic's budget. Or like you said, vaccines for thousands. The trade-offs are just brutal.
They really are. And it's not just the money, is it? It's the whole infrastructure.
Right, the logistics.
Yeah, you need the drug to be consistently available. That's hard in many places. You absolutely need a reliable cold chain refrigeration for the injection.
Which you can't take for granted.
Not at all.
Mm-hmm.
And then you need the ability to monitor them long-term, regular labs, specialist visits. That capacity often just isn't there.
So given those massive barriers, cost, logistics, what was the takeaway? The recommendation for clinicians working in those constrained settings?
It was very direct.
Yeah.
Prioritize. You have to prioritize the kids with a clear, definitive physiological need.
Meaning confirmed classic GHD or other conditions where GH is truly replacing a missing function.
Exactly. Those where GH isn't optional, it's essential for physiological health.
So essentially the argument is that in these settings, you just can't justify using those incredibly scarce resources to make a non-deficient child a bit taller.
That's the unavoidable conclusion, yes. The marginal benefit for ISS, that modest height gain, it just doesn't stack up against the potential to use those same resources for, life-saving interventions for many other children with acute conditions.
It's a stark resource allocation reality.
It absolutely dictates the decision-making process. It shifts the goal away from maximizing height potential towards ensuring necessary physiological function within an incredibly tight budget.
Going back to some of the clinical nuances for a second, the dosing details were interesting too. How the reason why a child is short affects the treatment approach.
Right. And what struck me was that the starting doses recommended for ISS were often higher than for standard GHD.
Really? Why would that be?
Well, they mentioned a common starting point around 0.25 milligrams per kilogram per week for ISS. The thinking, I guess, is that you're trying to get a strong response from a system that isn't totally deficient, maybe needing a bigger push than someone with classic GHD.
That makes sense, trying to overdrive the system a bit.
Maybe, yeah. And the complexity kept layering on, like with the puberty blockers, the GnRH agonists, for potentially adding height.
Oh yeah, that adds a whole other dimension. Timing is critical there, right?
Absolutely critical.
Yeah.
Bone age is the deciding factor. Using blockers delays puberty, gives GH more time to work, stretches out the growing period. But, as they stressed, if the bone age is already too far along, if those growth plates are starting to close, delaying puberty won't help much. There's just not enough growth potential left, no matter how long you hold off puberty. It all comes down to how much growing room is actually left.
Got it. And then there was that point about long-term treatment, which I thought was really useful, that isolated GHD diagnosed in childhood doesn't necessarily mean lifelong treatment into adulthood.
Yes, that's such an important practical point. Don't just assume it's permanent. You need to reevaluate when they finish growing, potentially stop the GH. Apparently, some childhood GHD causes can resolve or aren't relevant in adulthood.
So pulling it all together, the move towards clinical integration over single tests, the unavoidable impact of that $30,000 price tag, the need to really define physiological necessity. What's the big message you think people should take from all this?
I think it's that the clinical science, knowing the pathways, the drugs, that's vital, obviously. But it's only half the equation, maybe even less than half sometimes. The practical realities, the resources, the feasibility, they're just as critical in shaping what truly constitutes optimal care for a patient. You're constantly doing this balancing act.
That really sums it up. And it's why the session felt so grounded, I think. They weren't just presenting data, they were talking about navigating the messy reality, like suggesting that 6-month trial of GH if the diagnosis is borderline.
Right, the therapeutic trial. See if you get a real growth response.
Yeah. If you don't see a clear acceleration in growth after 6 months, you stop. Saves time, saves that enormous cost, avoids unnecessary treatment. It's a pragmatic approach to uncertainty.
And they were really open, weren't they? All the live Q&A, offering to discuss cases by email later. It felt very supportive. Honestly, anyone listening who deals with pediatric growth issues should really try and find the full recording of that presentation.
definitely. It was put on by GPED, the Global Pediatrics Endocrinology and Diabetes Group, and they mentioned their virtual annual meeting is coming up end of November, December sometime. So these conversations are clearly ongoing.
Which leaves you with a final thought, maybe.
Yeah.
When